This is part 3 of the lecture Fluid and Electrolyte Imbalances and Surgical Nutrition by Dr. Hesham Akkad, Professor of General Surgery, Ain Shams Medical School. We have discussed in the previous two lectures the fluid and electrolyte imbalances and acid-base imbalance. In this lecture, we are going to continue with the surgical nutrition. This slide is to remind you with the ILOs of this lecture. Surgical nutrition is any form of nutritional support that is given to the surgical patient other than the natural oral intake. It could be complementary to inadequate oral intake or the only form of nutrition. Enteral nutrition is when the nutrition is through the gut, and parenteral when into the bloodstream directly. Parenteral nutrition might also be complementary to inadequate enteral route. Total parenteral nutrition is defined as the intravenous administration of all nutritional requirements without the use of the gastrointestinal tract. Poor nutritional status can be assessed as we shall see in the following slides. A catabolic phase follows an insult immediately. With elective surgery, it lasts an average of 5 days but is much longer with severe trauma, burns, and sepsis. The most characteristic of this phase is the breakdown of body proteins with increased nitrogen losses in urine. The body uses proteins for its energy demands rather than glucose. Therefore, glucose infusion only diminishes protein breakdown but does not prevent it completely. Any protein given at this phase will be utilized catabolically. It is best to anticipate conditions that are associated with prolonged fasting, associated with additional nutritional needs that could not be met orally, or conditions of malabsorption. Surgical nutrition should be started early before conditions leading to malnourishment develop or worsen. Such conditions, common in surgery, are shown in this slide. There are many laboratory and clinical measurements to assess malnutrition. Most of those methods are used for the chronically malnourished and are repeated to assess the progress of nutritional improvement. In the surgical patient, where there are often rapid weight and muscle mass losses, most surgeons rely mainly on weight loss or gain, nitrogen balance, and serum proteins including albumin. Enteral feeding is preferred whenever possible due to several advantages. It is more physiological because nutrients do not bypass the portal flow to the liver, and so the liver acts on them. Also, lack of food in the gut results in mucosal and lymphoid atrophy, leading to malabsorption later, and breakdown of mucosal barrier against infection. It is also less expensive than parenteral and avoids complications related to central catheters. The routes of enteral feeding should be chosen carefully according to the cause of malnourishment, expected duration, associated disease like gastroesophageal reflux or chest infection, and the further surgical plan. Nasogastric tube feeding is a tube passed through the nose down to the stomach. If its tip passes through the pylorus to the duodenum and then the jejunum, it is called nasojejunal feeding and is used to diminish reflux. It might also be placed transorally in unconscious patients as it is uncomfortable orally for the awake. A gastrostomy tube is a tube passing from the right upper abdominal quadrant into the stomach. If the patient has no esophageal stricturing or injury, it could be passed endoscopically because the tube is passed with its rear through the mouth to be delivered through a small incision in the skin. The stomach, being capacious, allows intermittent feeding and bigger volume of food over the day compared to feeding jejunostomy tubes. Feeding jejunostomy could be done before major surgery for the malnourished or in association with a major surgery when prolonged fasting is anticipated or as a sole procedure in the malnourished complicated case where a feeding gastrostomy is not desirable. It is rarely adequate on the long run, but can be supplemented by parenteral nutrition. Parenteral nutrition should be avoided if enteral alternative is possible. Also, NPO for less than 5 days is managed by infusion of electrolyte solutions with 5 to 10% dextrose in peripheral veins. Anticipated death within few days due to terminal illness prohibits initiation of parenteral nutrition unless already established. Parenteral fluids induce thrombosis when delivered in peripheral veins. The tip of the catheter must reach the superior vena cava or close to it. Transfemoral vein route into the inferior vena cava is less commonly used. A long catheter can, however, be placed through the basilic vein, which is a peripheral vein, and is threaded till the superior vena cava. The position of the catheter tip could be confirmed radiologically. Such long catheters are more likely to block if not used properly, but are easier to introduce. Peripherally inserted central catheter is an alternative to central catheters in places where TPN is needed with lack of expertise to introduce central catheters, or if central catheter introduction is difficult or hazardous, like in cases of surgical emphysema of neck and upper trunk, or pneumothorax induced by trials of internal jugular insertion on one side. They could be used for short-term TPN to avoid complications of central catheters. This diagram demonstrates the position of the peripherally inserted central catheter. The insertion of central venous catheters is best done in clean environment with aseptic precautions. Suitable places are the OR or in the ICU. The patient should be lying on a bed that can be tilted head down to avoid air embolism. X-ray must be done post-insertion or after failed trial on one side. If there is pneumothorax, it is managed as appropriate, and trial on the other side is contraindicated except after the lung on the affected side is well inflated. Infection at catheter entry site is one of the commonest complications of central lines. For long-term use, a subclavian catheter, which is placed through a puncture just below the clavicle, is tunneled with its proximal part subcutaneously under the skin of the chest wall for 10 cm. The end of the catheter is delivered out of the skin for TPN use. For chemotherapy administration, the catheter end is cut short and connected to a chamber implanted under the skin. The medications are injected through the diaphragm of the chamber. This diagram demonstrates the common routes of nutritional delivery. Catheter-related complications must be guarded against by aseptic dressings of the entry site to decrease infection, by avoidance of its use for injection of medications to avoid its blockage, and by meticulous technique during insertion. Catheters need replacement when occluded or infected. The tip of the catheter must be cut aseptically and sent for culture and sensitivity. There are many formulas for various nutrients with various concentrations. All are hyperosmolar and acidotic. The details of calculations are not required by the undergraduate students. However, you should know the requirements in broad lines. Remember that whatever the nutritional calculations are, they must be delivered in the proper volume need. 5% dextrose or electrolyte solutions like 0.9% saline or Ringer's solution may be added to complete the water and volume needs. Urine output is a good monitor in absence of renal failure. Other minerals like potassium, calcium, magnesium, phosphates are to be added if not adequately included in the formulas used. Vitamins and trace elements are supplied in ampoules for IV use. The normal daily requirements of non-protein calories may double with severe inflammatory conditions and burns. Glucose is needed in bigger amounts than normal to combat the catabolic phase of protein breakdown. Increasing the protein intake alone does not reverse its catabolism. For each gram nitrogen, at least 150 kilocalorie must be given as carbohydrate in order to spare the protein. Therefore, the infusion of both protein solution and concentrated dextrose solution are best infused synchronously. The calculated requirements are given gradually over several days until the body adapts to the hypertonic ketoacidotic solutions. Insulin is commonly added to concentrated dextrose solutions. If so, then the potassium needs can be added to these bottles, as glucose insulin tend to cause hypokalemia due to the shift of potassium into the cells. Fat emulsions are usually deferred during the first period, and some protocols avoid their use. Actually, fat is needed to provide the essential fatty acids besides its caloric value. The three main nutrients are given either in separate bottles or as manually mixed preparation or ready-made formulas. There are two methods of infusion. The continuous is through an infusion pump and given over 24 hours. This method is suitable with big volume needs. Infusion in a rate that finishes within 12 to 18 hours has the advantage of allowing rest and better sleep for the patient. This slide summarizes the main complications of TPN. We have spoken about mechanical complications of insertion. Infection should be diagnosed when the patient develops fever and rigors of septicemia. Superficial entry site infection may be absent, but the bacteria may be introduced through the catheter. Enteral nutrition allows for increasing and decreasing absorption of some electrolytes, and the slow absorption allows for the homeostasis to adjust, like the kidneys increasing sodium excretion, for example. Direct administration or lack of administration into the bloodstream result in ups and downs with likely fluid and electrolyte imbalances. Insulin resistance of muscle cells with stress plus the surges due to concentrated glucose solutions might cause hyperglycemia. Insulin added to these solutions for that reason might paradoxically cause hypoglycemic attacks. Maintaining a fluid balance by appropriate fluid balance charts and CVP monitoring is needed to avoid dehydration or volume overload. The catabolic status of illness is in itself metabolically acidotic. Most infusions are in additional acidotic. The most common of organ dysfunction is the liver. The exact etiology is not clear, but seems to be multifactorial. But liver enzymes elevate, although bilirubin remains normal. Cholestasis might develop, and in this case bilirubin may rise, especially in children. The effect on the liver is aggravated by sepsis. Bone mineralization is abnormal because of calcium and phosphate imbalances. The shown guidelines are variant from one institute to another, but these are the common investigations with variable time frames. Now try to activate your memory with right or wrong answers for each statement. Thank you, and be ready with your questions in the face-to-face session.